Yeah, I think we could probably get started, Shannon, if that's okay with you.
Absolutely.
So I welcome everybody to our Grand Rounds, Department of Surgery Grand Rounds this morning. Um, I'm going to hand the reins over to Dr. Fraser, but I know we did send an email out, and I know everybody never always reads all of their emails extremely carefully because there's so few that come every day. In case you missed it, I'm very happy and really delighted that Dr. Fraser has taken on a new position that was created in the department, Vice Chair for Faculty Life. This is really a new position to work on community building and engagement at the department level. And I'm really thrilled that Shannon has taken on this role. I think she's perfect for it. As part of what I've asked her to lead is this concept of being able to provide useful feedback, and that's linked to potentially coaching, and so that we as a department get some information or support that we need to always continue to reflect on the ways that um, our actions impact others, and being continuing to evolve personally and professionally in our careers in our department. So I'm very happy to hand over to Shannon to introduce a little bit more of the program and our speaker this morning.
Thanks, Leanne. I'm delighted to have this opportunity to work with all of you, and I'm sure I will be having more intimate conversations about what you think would be helpful for all of you in the coming months. But today is really about the Pulse 360 program, and I'm really happy to introduce Dr. Larry Harmon. He's the lead on the Pulse 360 program that actually is been deployed. Some of you in the pre-show kind of heard some of the places that it's been deployed, and he's actually in Los Angeles now with the American Board of Thoracic Surgeons to roll it out with them. And because it's such a well-respected program to give feedback to medical leaders and physicians about how they communicate, how they interact with their colleagues in their day-to-day practice, professional lives, that a lot of us are unaware of, or come out of annual reviews sort of thinking, well, I don't really have any information that I can action on. So this is the beauty of this program, that you get to choose who you want feedback from, and get some information that you can then reflect on, as Leanne pointed out, and think about some personal growth opportunities in your professional life. It's well known. It's been deployed in multiple academic centers, Harvard being the one that is often cited. But Larry will tell you a little bit about more where it's been deployed and how it's been used. And the idea is that we're going to roll it out with some of our identified leaders. Excuse me, I have a horrible cold. Some of our leaders in our surgical department to get some of the kinks out, and then deploy it to all our members to have the opportunity for that personal growth. So I'm going to hand the reins over to Larry, and he'll give you some more information, specific information about how the program works, and then fields all your questions, because I'm sure there'll be a few.
Well, good morning, and thank you, Shannon and Leanne. I'm going to be switching to screen share, which, is always a challenge. So let me go ahead and do that. There we go. And you should all be able to see Pulse 360 orientation. Can you see that?
Yep. Yep.
Yes.
Great. Perfect. So what I'd like to do is cover four different areas very quickly. The first is I'd like to share some information about feedback in general. In other words, what do people think about feedback? Are people giving feedback? Are surgeons receiving feedback? So that's first. Second, I'll go through some outcome data from research on the Pulse 360, in particular, mostly with surgeons. And as Shannon said, a lot of it comes out of the Harvard hospital system, like Mass General, Brigham and Women's, et cetera. Then the third part is I'll show you a 5-minute video that is designed to share with you and give you information about how the program will work for your department. And then the most important part of the whole grand rounds is the last part, which of course is Q&A. So I'll try to move through quickly so we'll have plenty of time for Q&A afterwards. So relevant financial disclosure in the interest of that, I head up the Pulse 360 program. So I'll begin by just asking about feedback. So somebody, you ask a colleague or a trainee or a leader, could you stop by my office? I'd like to give you some feedback. My question to you is, what's their first thought? And usually their first thought is some version of this. It's like, uh-oh, what did I do wrong? I must be in trouble. Sometimes when people are graphic, it's, oh, blank, and blank is a 4-letter word, which I won't say. The bottom line is that most of us have a negative association when it comes to feedback. And I'm a clinical psychologist. So of course, I look at these things from a psychological perspective. And of course, everything starts in childhood. So when we ask ourselves, why do we have such a negative perception of feedback in general? The answer is, as children, our parents tended to criticize us rather than compliment or praise us. In fact, a study I read many, many years ago said on average, there were about 10 criticisms for every one compliment or acknowledgement or praise or validation. And for most of us who are more late career, we grew up in an era where parents did tend to criticize more than praise. Of course, the earlier career surgeons hopefully will experience that change in parenting where parents tend to focus a lot on bolstering our self-esteem, creating confidence, making us feel good about ourselves. But the bottom line is, now that we're adults, here we are. We tend, if we give feedback, it tends to be what I call feedback. In other words, it's based on a retrospective assessment of what the other person has done. That tends to make people feel defensive. Very rarely do we naturally and easily give what I call feed forward. Feed forward is, here's how you can do it better moving forward in the future. And hands down, the bottom line is feed forward as a tool for giving feedback tends to be received much more favorably with much less defensiveness. But most of us have never been trained in how to give feedback. And so the times that we've tried to do it, often it hasn't gone as well as we've expected or hoped. And in turn, many of us have simply given up and we give no feedback. And part of that is we've learned this sort of equation. Feedback equals criticism, and criticism equals negative feelings. And so what do we tend to do about negative feelings? We avoid them. It's what I call the negativity bias. This is one of my very favorite studies. So this was done at Harvard Business School, and they had survey takers who would go up to Harvard Business School students in the courtyard and say, I'm taking a survey. would you mind filling out XYZ? Now, the survey takers all had X on their face. And I'd like you to guess what percentage of the subjects told their survey takers that they had any of X on their face. Now, X equals a chocolate smudge, a red marker on the nose of the survey taker, or a stain on the shirt. And so maybe you could silently ask yourself, would 50% of the Harvard business students who were approached by survey takers, would they point out, hey, you've got a mark on your face or your shirt? Would 40%? Would 30%? Whatever you guess, the answer is only 2.6%. So 2 or 3 out of 100 spoke up. Now, that's about Harvard business students. They're a fairly assertive bunch, certainly bright, not shy, and yet very few of them gave that feedback. Now, when it comes to physicians, there are very few studies on physicians giving feedback, but here's one. 45% of physicians, by the way, this was done in England, 45% did not give constructive feedback to their colleagues. 42% do not proactively ask for honest feedback, and 39% won't or haven't asked for the support they need to fulfill their role. Now, I suspect that this is an underestimate, and I'll tell you why. These were based on survey self-assessments. In other words, asking physicians to fill out a survey on their own behavior. Now, we know that self-reports are often aspirational. People tend to inflate the positivity of their response. It makes them feel good. And so my guess, being very candid, is that it would probably be about twice the percentages if we were looking at what people actually did. Now, why don't we give feedback? Well, as I mentioned, we tend not to give it well, and many of us have had bad experiences giving feedback. People have cried, people have been upset, etc. But I think it starts sooner. And again, I'll put my clinical psychologist hat on. As children, we all learned if you don't have anything nice to say, ... You all know the answer to that because it's imprinted in our brains. If you don't have anything nice to say, don't say anything at all. So we don't like to give feedback, and this is more research-based, for a variety of reasons. The 3 main ones are we're afraid of hurting people's feelings because we've found that people get upset when we give them feedback. Now, that's largely because of the way we do it, but nevertheless, we're human. We do the best we can. The second reason is that we avoid sharing negative feedback that others could resent. In other words, it's not only that we're afraid of hurting their feelings, we also don't want to hurt our own image, the image that we project to others. We don't want to be perceived as offensive or impolite. And then finally, we lack the motivation often. We're too busy. To give really quality feedback requires that you prepare for it, you think about it, you analyze it, you structure it, you think about feed forward, like how the person could do better in the future. Or maybe we just don't care enough to spend the effort and time to give feedback. Now, when we look at some stats on receiving feedback, obviously the reverse of giving it, and these stats are not based on physicians. These are based on just regular frontline physicians, or frontline employees, excuse me. Only 5% believe that their managers provided candid feedback about how they performed on the job. Imagine 95% did not believe that they got candid feedback. 19% of millennials say that they receive routine feedback. However, big but here, only 17% of the 19% said that the feedback they get is actually meaningful. Now, 17 times 19, what is that? Roughly 3% of the group felt that they received meaningful feedback. 43%, and I find this fascinating, 43% say they want to get praise or recognition. However, even more, 57% would prefer to get corrective feedback. In other words, how can I do better? What did I do wrong? What can I do that would make my outcomes improve? 72% say that corrective feedback would actually improve their performance. That makes sense. But 94% said that it would have improved their performance. And here's the emphasis, if presented well. So I think in particular, when it comes to receiving feedback, most physicians, and especially surgeons, tend not to receive much feedback at all. In fact, I think surgeons have a distinct disadvantage, and I'll tell you why. So these are the percentages of what people perceive as highly prestigious, highly respected, admired occupations. So 88% of the survey sample felt that physicians were amongst the most respected, admired, and prestigious professions. Now, that puts you all at the top in several ways. The higher up you go in terms of status, the fewer people actually give you honest feedback, which is why very often people who are at the top, deans, department chairs, and chiefs often don't get what I call feed up. Feed up is when frontline people give upward feedback. Surgeons, in particular, when you look at all physician specialties, are at the top of the hierarchy. And so even more so than physicians, medicine docs, perhaps, primary care docs, surgeons are the least likely to receive honest feedback. Now, the problem with that is when you don't get honest feedback, you develop blind spots or maybe blurry spots in that you don't really know how your behavior comes across to others. And so that can be a problem. However, I think even if we don't know how our behavior comes across to others, we still get feedback, whether we like it or not. And this is one of my favorite cartoons. Whenever I get mad at you, you never seem to get upset. How do you manage to control your temper? He asks. She responds, well, I just go and clean the toilet. And he's confused. And so he asks, well, how in the world does that help? And she responds very simply, well, I use your toothbrush. In other words, we may be getting feedback that's indirect, passive aggressive, but we are getting feedback. And as Leanne and Shannon said at the beginning, this Grand Rounds and the Pulse 360 program is about receiving actionable, direct, helpful, specific feedback that's designed to improve behavior. So why 360 feedback? Well, it's certainly very commonplace in Canada and the States in terms of Hospital executives, administrators, managers, leaders tend to get feedback. They've been doing that for years. It's only been in the last 10 or 20 years, we started 22 years ago, that physicians, frontline physicians, are getting feedback. It's a very useful tool because it's formative. It's designed to provide you with insight into how your team members are perceiving your behavior. And I think this is really important. Those of you who are human, and I assume you all are, human nature says that we're going to worry that we're going to get negative feedback. But the reality is the vast majority of physicians and surgeons receive positive feedback. And the positive feedback is validating, it's pat on the back feedback, and it's potentially morale boosting, as I'll talk about a little bit later. So that's why we developed the pulse. We developed it for three main reasons, signified and characterized by the acronym. First, we wanted to build a process that was just for physicians. And although it was later expanded to include physician leaders, allied health professionals, nurses, administrators, medical students, trainees, etc. The second factor is that we wanted to help develop universal leadership skills. In other words, captain of the ship skills. Now, that's been characterized by the CanMed's core competencies of professionalism, communication, collaboration, but that is essentially what universal leadership skills are. And most importantly, we wanted the process not to just be an evaluation, but rather education. In other words, developmental, formative, helpful. Now, it was mentioned at the beginning that Pulse is used widely across Canada and the States. And here are some Canadian as well as US academic medical centers and hospitals at which Pulse is used. At McGill, for example, we are just wrapping up your radiation oncology department. That was launched about a month ago. At McMaster, we just launched a program yesterday, as a matter of fact. At University of Ottawa, all the program directors get Pulse 360 feedback on the program director Pulse, and all trainees get feedback, usually at the end of the PGY 1 year and in their next to the last year. In the States, Boston Children's Hospital on the right side, all 1,000 physicians get feedback on the Pulse 360 every 2 years. 100% of the physician faculty participate. And then there are a number of other programs going on, many surgery departments, et cetera. At University of Miami, which I notice I've just left out, we're just finished up a few months ago, the orthopedic surgery department, for example. So let's look at some of the outcome studies. You're all scientists, so I want to present you with some data. We wanted to ask a number of questions to the data. This, by the way, is a journal article published in the Journal of the American College of Surgeons. Some of you may be familiar with a well-known Harvard surgeon by the name of Atul Gawande, who developed the Safe Surgery Checklist. And he's a co-author along with most of the Harvard surgery hospital chiefs and chairs. And essentially the finding based on 385 surgeons was that the Pulse 360 was accurate, that it had value. In other words, 77% of the surgeons were willing to participate again. 82% of the raters were willing to provide future feedback on the 360. And most importantly, number 3, 60% of the surgeons reported changing how they practice and interacted based on the feedback they received. Now, the conclusions of that study were very simple. 360-degree feedback is practical, systematic, and accurate, at least subjectively, without undue burden on the raters. And that's really important. The raters were surveyed and they did not report feeling survey fatigue, etc. in general. And overall, the process was found to be quite beneficial in terms of behavioral change. And this was according to the surgeons themselves, as well as their team members. Now, the next question we asked, is there any association between Pulse 360 feedback from team members and patient experience or patient satisfaction? And this was done also at one of the Harvard hospitals and was in the Journal of Clinical Orthopedics. I'm a co-author on that article. And indeed, about half the Pulse questions do correlate significantly with patient experience, especially with respect to correlating with patient experience surveys on whether or not the patient found that the physician was respectful. And this is based on about 8,000 surveys. And then the next question we asked, and this is an interesting one because I have mixed feelings about this study, is are pulse behaviors associated with surgeons more likely to receive malpractice claims? Now, I emphasize the word claims because in the States, people file a lot of claims, not so much in Canada. And many of those claims are perpetuated by lawyers who, being very candid, want to make money. And oftentimes the surgeon, in fact, did nothing wrong. There was a bad outcome which could occur, but it wasn't the surgeon's fault. And there was nothing technically wrong. But it does underscore, and this is important, that the way the surgeon interacts with the patient can certainly impact the likelihood of a patient filing a claim or being resentful and angry enough to do so, even when there is no technical mistake. The next question, and also I think extremely important, is do physicians improve? Now, this was a mixed group that included medicine docs, primary care family medicine docs, and surgeons. Now, you may have to squint a little bit, apologies, but if you look at the arrow at the very bottom, you'll see that physicians who started with the lowest scores had the greatest degree of improvement. If you look at the lower left, you'll see that that blue line at the bottom, that's surgeons. Although surgeons started lower in general than the other two groups of medicine and primary care docs, they showed the greatest improvement overall. So yes, physicians can change. When we broke down what those changes were about, what behaviors more specifically, we found that question number one, which we call the insight question, improved the over 25% amongst those in the bottom third. And you can see that, and this tends to be borne out in multiple internal studies as well as published studies, that the bottom third improved the most, the middle third improved mildly or moderately, and the top third typically improve not at all, no change. Now, based on a lot of analysis and working collaboratively with the CMPA of the Harvard hospitals, it's called CRICO or CRICO, they have partnered with us to roll out the program in most of the 26 Harvard affiliated hospitals. And that started last year, and we have just some preliminary data. And what we find is the bottom 10% in the group improves 16%, The bottom third improved 7%. Middle third, non-significant, very slight improvement. Top third, no change. So, and then one of the hospitals that we work with has been using Pulse for a number of years, and we started tracking about 5 years ago. And we found, and this is where all physicians do the program, we found that there's been a steady improvement in scores. Now, the next question we wanted to ask is, how do physicians perceive the Pulse 360? And as you can see, overall, the perception has been quite positive, actually more positive than I would have expected. And then the final slide addresses a question that often comes up is, do Pulse 360 scores differ based on gender, age, being a country of medical training, et cetera? And in our study, we found that there was no significant difference based on those factors. Some other independent studies, not with physicians, have found similar findings. I'll wrap up the data analysis just by mentioning, or sorry, the statistical part of the presentation. Just the reason I'm in Los Angeles today is that the American Board of Thoracic Surgery is starting this year is now requiring all candidates for board certification to do the Pulse 360 in their last year of residency. And the goal is to help provide feedback and insight into those who are doing well so they can feel more confident, and also to help residents who may have a few rough edges perhaps to improve in their interpersonal communication, collaboration skills prior to their first job as attendings. And so I'm here to help and support rolling out that initiative. So I just want to wrap up by saying about 85% of physicians receive a lot of very favorable feedback. Now, that's not to say that there may not be some suggestions for improvement, but overall, the process can be quite morale boosting. So let me shift to the video here, and let's see. So I'm going to be showing you a very quick video on how the program works, 5 minutes or so. And then I'd like you to jot down some questions because I want to leave some time for that. Can you all hear it?
Welcome
Yeah.
to the Pulse 360 program. This video will answer the 7 most frequently asked questions. First off, what exactly is Pulse? Pulse is a 360-degree survey feedback program that has been used at academic medical centers such as University of Ottawa, University Health Network, Hospital for Sick Children, McMaster, Dalhousie, Johns Hopkins, Yale, University of Michigan, UCLA, and over 10 Harvard-affiliated hospitals, including Mass General, Brigham and Women's, and Beth Israel Deaconess, as well as other academic and community medical centers. Pulse is a good to great program and an opportunity to get helpful good to great feedback. Pulse stands for Physicians Universal Leadership Skills Education, and across more than 2 decades, about 15,000 physicians, leaders, providers, residents, and other healthcare professionals across more than 700 facilities have received feedback from nearly 1 million Pulse surveys across the US and Canada. Here's how the feedback program works. Pulse will email you a link so your designated leader and you can select your raters. Shortly after your leader augments and validates your list of raters, Pulse will email you the survey to score yourself. Make sure to score yourself the way you honestly think you are, not the way you think others might score you. What are some of the Pulse 360 questions? There will be questions such as treats team members with respect, keeps team members informed, and communicates clear expectations. How do I get my feedback? Once your feedback is finalized and approved by your designated leader, we'll send you an email with a link to an online calendar so that you can schedule a convenient time to receive your feedback from one of the Pulse coaches and begin your debriefing. The Pulse coach will then review your feedback with you and help you select a few good to great excellence goals, which will be copied to your designated leader and then emailed periodically to you as helpful reminders and reinforcers. All coaches are trained in Pulse's feedback-assisted coaching and education model, have extensively coached healthcare professionals, and are either certified coaches or have at least a master's degree in psychology, healthcare, or education. If you have any outlying scores, your Pulse coach may discuss a development plan for any follow-up calls and brief online educational modules. What does a Pulse 360 summary report look like? Here's the cover page of a sample Pulse 360 report. The cover page shows how many raters gave you feedback, as well as the benchmark comparison group being used. We call this the graph page. This is an aerial view where you can see how your self-rating flows in comparison to the ratings of others. This is the color-coded page. Green is great. Green means you scored more than about +1 standard deviation above the comparison mean. If there's no color, it means you've scored mid-range, between +1 and -1 standard deviations. Yellow means it's below -1, but not more than -2, which means caution. If it's more than about -2 standard deviations below the mean, then it's highlighted in red. The last section of the Pulse report shows your raters' written comments that may be clustered into themes. How does Pulse provide fair feedback? Pulse strongly believes that for a feedback system to be effective, it also has to be fair. First, we ask each rater how often they work with you, which is called the familiarity index. Next, algorithms determine if any scores are based on limited data. Your Pulse report will not display a score based on 1 or 2 raters. Next is inappropriate or non-constructive comment deleted, which means that Pulse, as well as your designated leader, may delete comments deemed to be highly inappropriate, that may say more about the rater than you, or overly divulge the rater's identity. Finally, our system looks for rogue raters. These are raters who appear to be providing extremely harsh ratings, and Pulse may remove that rater's feedback. How can you give fair feedback? In addition to receiving feedback, many of you will be giving feedback, and giving fair feedback is easy. Most Pulse surveys are short, so it should only take 1 to 2 minutes, and make sure to follow the ABCs. Stay anonymous by not writing comments that identify you. Give balanced feedback, which gives credit where credit is due, but also lets the individual know specifically what they can do to be a better team member. Describe changeable behaviors that a motivated person could improve. Be selective and sensitive about your comments. In other words, don't unload everything under the sun you might want to say. Remember that about 85% score quite well and get favorable feedback. Given how challenging working in healthcare can be these days, a pat on the back goes a long way.
All right. So I'd love to hear your comments, your thoughts, any curious questions, anything you're wondering about.
And you can go ahead and either raise your hand or just put your question in the chat if you like. I don't see anything in the chat yet. I think you may have answered everybody's questions, Larry, but we'll give them a few minutes to digest.
Sure. Thank you, Kevin. Any data on recruitment and retention in the OR? Wow, that's a great question. No, unfortunately, we have not been able to study that. And I think it would be difficult to study because there's so many factors that have to do with turnover. for example. But I'd love to study it, and if any of you'd like to partner on a project like that, Kevin, I'd love to talk with you about it. Yeah. The next one is, what's the duration of change? Um, it depends. I think when I'm going to share my opinion. We've looked at whether or not people maintain their improvement as long as they are continuing to get periodic feedback. And we know that improvement tends to occur and it becomes fairly durable as people continually, or periodically, I should say, get feedback. Think of it like roadside radar. Well, you're getting feedback that maybe you're exceeding the speed limit. And as long as that roadside radar is on the side of the road, you're probably going to drive slowly. But if they remove it, then there's a good chance that you'll start to speed up again. Um, so, so the answer is, I believe, as long as people are getting feedback, and we've seen this in our own data, they seem to maintain improvement. But we don't know what happens when feedback stops because we don't have a way of evaluating it. Yeah. Thanks, Susie Lau.
I just wanted to just clarify one thing that the video and you mentioned before is who gives the feedback and how that plays out operationally. Some of you may understand that the need to have both your McGill email addresses and your .med email addresses active, because some of the feedback we might be asking people to give might be from our nursing colleagues or our allied health colleagues. So we're trying to create a directory of people that we all interact with. It would be actually easier if the whole of McGill Faculty of Medicine was doing that, because then it would be quite easy to capture that. But because we interact with so many different groups, we're trying to build that directory already. So if your one or the other emails is not active, you might consider working with IT to make it happen.
Yeah, that's often the very big challenge, Shannon. All of the participating Harvard affiliated hospitals, they have to provide the entire directory of all faculty, physicians, employees, because that's the best way. Hopefully one day we'll get McGill to do that. Jason writes, you present people's outcomes relative to their group's means. This kind of approach has pros and cons. Can you talk about the context this works well in and does not? I understand it's only part of the assessment. Yeah, I mean, personally, I think that it's the comments that provide the most actionable feedback, but the numbers, the scores, when compared to, for example, other surgeons, and there's about 2,000 surgeons, many of them come from academic medical centers that I had listed, is the closest thing we have to a peer group. So when we talk about their group, we're really not talking about how you all compare to other McGill surgeons, although we could do that, but rather a broad cross-section of surgeons. And I think it works well because if you get a lot of greens, that's morale boosting. You feel good because compared to your peers, you're doing really well. And if you get some yellows, some below average scores, for example, I think it gets your attention and it says, wow, I thought, all surgeons tended to be brusque and maybe a little annoyed at times. But even compared to my peers, I'm showing more annoyance that perhaps is showing overreaction. So I think in that way, it can be very, very helpful. But ultimately, the comments that people write, and by the way, please write a lot of comments if you get a survey about one of your colleagues, because those comments, surgeons take them to heart, which is good. They look at them, they think about them, and it resonates. Thank you for that, Jason.
I think that looks like oh, Jason, thanks, Jason.
The presented research was at the time level. Have you or others looked for underlying factors in the surveys? There are various psychometric advantages to doing so if they can be identified. So I'm not a statistician. Our vice president is. So I'm not sure that I can answer that. I'm not sure what you mean when you say underlying factors, but probably someone like you could do some fancy stuff with our data, except it's obviously all very confidential.
I meant to
So,
say item level. Apologies. That
oh,
probably didn't help. Item level, not time level.
oh, yes, yeah, well, we know that most surgeons score quite well on any clinical items like sound clinical judgment. Um, but that could be because of the academic medical centers with which we work. They're all competent. Um, at the item level, clearly the more communication interpersonal questions are, we find that there's much more variability. A concern raised when collecting data, how can my feedback remain anonymous if the surgeon personally selects a limited number of raters? Well, there are minimum number of raters you can select, number one. Number two, your chief or chair or division chief, division head, or whomever is designated as the validator has the option of adding any missing names to ensure that there's a bell-shaped curve of raters. So you never really know who gave you feedback. You don't know the number of raters per group, other than it's above a minimum in order to ensure that there's anonymity. And so we do our best to mask the numbers. We only show the total N, not by physicians versus, let's say, non-physicians. And then in terms of comments, our software has an anonymity editing process where it tends to, if a rater wrote a paragraph, it would take each one of those sentences, look for a certain key word which was preloaded into our system, like frustration or team or skilled or excellent. And then it'll organize comments around those keywords in order to attempt to create behavioral themes. And those themes are in the category of starting. What would you like this physician to start doing more of? What would you like them to do less of or stop? And what do you want them to continue or keep on doing? Um, oh, by the way, we did do a factor analysis a number of years ago, and we found that the factors boiled down to motivating behaviors and discouraging behaviors. So they tend to hang together as large factors rather than small ones. Is there not a danger that the surgeon will only select raters that may rate them well? Yes, and we know that, and that's one reason why it's virtually all of our programs require a validator. And typically that validator is the division chief. And so it's the validator's job to make sure that they review the list and confidentially add any missing names. So you don't know which names they've added in order to preserve the anonymity of raters. And also there's another factor, which is we want you not to focus on who may have given that feedback, but rather on what the feedback says. And so we do our best to mask and really heighten the anonymity. We seem to be in a culture of anonymity, although I understand the reasons. I wondered if this leads to gaming or hypervigilance of the system. You know, if you look at that very first study from the Journal of the American College of Surgeons, the chiefs and chairs report, I think it was 77% reported that the feedback for their faculty members was accurate. And so I think anonymity does create a kind of honesty. I guarantee you, if you sat down with a group of nurses and asked them for feedback, I think you'd either get a lot of very positive feedback, accurate or not, it might tend to be inflated, or you might get silence, where people might be reluctant to speak up. And so it's unfortunate that we require anonymity in order to provide honesty or candidness or frankness, but that is the way human beings work these days. I didn't show it, but we did an internal study asking, I think it was about 1,000 raters, if now that you've given anonymous feedback, would you be more willing to give face-to-face feedback? And I forget the statistic, but it was a very high percentage said that they would be somewhat more, much more likely to give face-to-face feedback having given anonymous feedback. So our ultimate goal is to help develop feedback systems that eventually will be more face-to-face. But I think that's aspirational given how we're wired as human beings. How do you organize the division chief's feedback? Who is their lead? Well, division chiefs, their lead is the chair of the department typically.
I think just, I know we could go on
Yeah.
and maybe Jason and Larry will have a conversation, but I know
I
people
hope so.
who are. Question for me, will the results of the 360 be added to the annual performance evaluation? I wasn't, I think the main factor will be to give the feedback to the division heads who in general are delegated to give the performance evaluation. So I think this would be information that would be available for you to use in your annual meetings with folks. And certainly I will use it in my discussions with the division heads and leaders in the department. And as you said, Larry, we are going to start with the division leaders, the department leaders to kind of, and that will help us roll out some of the kinks. And maybe Shannon, do you have any information about timing and rollout from here that we could leave folks with?
Yeah, we're just finalizing the directory, and hopefully within the next month, the well, I think it's the program directors and the division chiefs and site chiefs that all get the first invitations. But hopefully within the next month, we're gonna touch base with the team to make sure that we have the directory in place and then get those invitations rolling.
Right. So I want to thank everybody. We had good engagement and participation this morning, and I really do hope we all engage. I will engage in this with a spirit of trying to reflect and improve, and have information that's actionable. And I look forward to working with your team, Larry, and with Shannon as well. Justine from the department and Maria Cortez is helping with this as well. And others I know because of you can imagine, I think we are going to roll this out to, something like 150 full-time members of our department. So you can see that might be some administrative hiccups, but you'll bear with us. And I know that we'll all work together in a spirit of just continuing to improve throughout our careers, which I know all of us are committed to. So I think I'd like to thank you, Larry, for taking the time to go through the data and explain the program. It was very useful. And for Shannon for chairing us this morning, and for all of you for attending, and have a great day. Thank you. Thanks, Larry.
Thank
Sorry,
you.
you got to take a little nap. I know it's very early. Thanks for waking up so early on the West Coast. We appreciate it. It seemed pretty
Thanks so
simple.
much.
My pleasure.
Have a good
Bye-bye, everyone.
Bye.
Take care. Have a good day, guys.